Welcome to Matters of the Mind. I'm Dr. Rick Adams, licensed psychotherapist and professor of psychology and human behavior. This podcast is designed to help you better understand how the mind is shaped and influenced physically, psychologically, emotionally, socially, and spiritually. For more than 3 decades, I've been blessed with a front row seat into the minds of humanity. And through this podcast, my desire is to use that experience to inform, encourage, and help others navigate the matters that affect the mind. Today, we continue our conversation on a subject that touches every area of life: mental health. Throughout this series, I've invited clinicians, counselors, psychotherapists, psychiatrists, and behavioral health professionals to join me in this discussion, because this is not a topic that I believe that should be handled alone. So today, I'm approaching mental health through, again, those 3 critical questions: where we are, where we're going, and where we're headed. Because where we are mentally, emotionally, and spiritually directly influences where we're going and ultimately where we're headed as individuals, families, and society. So today I'm honored to continue the conversation with my special guest, Dr. Sandra Rodriguez-Davila. Dr. Rodriguez is an adult geriatric psychiatrist with more than 17 years of clinical experience. Her work spans outpatient care, inpatient psychiatry, telepsychiatry, and specialized neuropsychiatric services. Dr. Rodriguez is the owner of St. Raphael Behavioral Health Services that's based in Lakeland, Florida, where she provides adult geriatric outpatient psychiatry care. She also serves as a consulting psychiatrist for Lake Nona Behavioral Health Services. Throughout her career, Dr. Rodriguez has worked extensively in hospital-based psychiatry, serving as an inpatient hospitalist across multiple medical centers in Florida, as well as emergency room telepsychiatry for HCA East Hospitals. Early in her career, she served at the James A. Haley Veterans Administration Hospital, where she provided geriatric outpatient care and specialized consultation for the Traumatic Brain Injury and Polytrauma Rehabilitation Center. Dr. Rodriguez has a special interest in metabolic psychiatry, including nutritional interventions for mental health symptoms, as well as safe psychiatric drug withdrawal and deprescribing. She completed her geriatric psychiatry fellowship at the University of South Florida and her adult psychiatric residency training at the University of Chicago Medical Center. Her research background includes work in neuroimaging, aging, and behavioral neuroscience. Most importantly, Dr. Rodriguez has dedicated her career to providing compassionate health care grounded in her belief that every person is unique and unrepeatable. Dr. Rodriguez, welcome to Matters of the Mind.
Thank you for having me.
Now, I want to begin by saying I have been looking forward to having this meeting with you. We've talked on the phone, we've shared clients, and I just want to say that I'm very thankful for everything that you do and how you do it, okay?
Likewise.
And again, with this topic, we've been talking about mental health.
Mm-hmm.
I've had other clinicians come in and other individuals that specialize in the field.
Mm-hmm.
However, when it comes to psychiatry, though, okay,
Mm-hmm.
you're one of the first individuals that my audience and others have had to been able to glean from, okay? And for 17 years, you've been in the field. Mm-hmm. So I want to start with the first question that I've asked everyone, and that is, from your perspective as a clinician and a physician, where are we, where we're going, and where we're headed? But first of all, from your perspective, where are we when it comes to mental health and psychiatry?
So where we are is really, I think at this point, a post-pandemic phenomenon, mm-hmm. that the rates of mental health issues have skyrocketed, basically. There's, a lot more people seeking care. But at the same time, there's other things going on that it's almost like a lot of people just seeking a diagnosis because mm-hmm. it's, the stigma on one hand is wonderful that it's a little less.
Correct.
But at the same time, I've also noticed that there's a lot of people just wanting to have a diagnosis for mental illness. So that's a little bit different than all my years of training, So that's kind of where we're at now. There's a lot of people struggling. There's a lot of people that need help. There's a lot of difficulties with access to care, and we all know that. Mm-hmm. Mm-hmm. And in a way, I also think that we're in a place where psychiatrists and anyone who prescribes is now at the point of that there should be a decision to make here, because the numbers of people on medication have also skyrocketed.
Yes, yes.
But at the same time, we see that, okay, if people are getting treatment and on medication, things should be getting better. But they frankly are not.
And that's where I've seen it too. Okay, between us, we have 50 years of experience, and we've seen a lot in our careers, and that's something you said earlier. I want to kind of stop with that conversation as far as people wanting a diagnosis. Okay,
Which to me was always like people had to be dragged into my office.
Correct.
And now it's like they show up and they're like, "This is what I have." They come with a
already
diagnostic
written down.
criteria. Yeah.
Already written down, and that's something that one of the other individuals that I spoke to, one of the other clinicians, talked about how the positives and negative of social media. And because some of them go on to the different sites, they find a diagnosis, they read it, they buy into it without that clinical insight to say, well, this is what it says, but let's look at what also your symptoms are. And before you self-diagnose, let's look at what really may be going on as a cause. So how do you then kind of direct them away from that when you as the clinician and as the physician don't see what they're seeing?
Absolutely, because also now everyone's a narcissist.
Yes.
They're throwing these things around, and so the way I take it is just as my practice hasn't changed much. I am very open. I want to listen to what they're saying and what their complaints are. But I do spend a lot of time with education, and being like, okay, this is this. And just because you have a few symptoms doesn't mean that you meet criteria.
Correct.
And just because someone in your family has told you you're bipolar doesn't mean you're bipolar. And that's my job. I'm going to help you to figure out if this is a reality in your life and if this is your diagnosis or not, or what else could be going on, taking so many other things into account that I know they're not taking into account.
Correct.
Because that's my job. That's what I've been doing. So
Correct.
17 years practicing, but how many years practicing as a trainee? That's more than 8 years,
Correct.
So with all of these years, I do know that these things happen, and I, for one, want to make sure I get the right diagnosis, because I'm going to be the one that's prescribing. Correct. And if we get the wrong diagnosis and you get the wrong medication, it'll cause a lot more harm in your life.
Correct.
So I want to help people get better.
Correct.
Not
Correct.
worse.
And with that being said, I often say that there's three things. I say that there's the accurate diagnosis, the wrong diagnosis, and the misdiagnosis.
Exactly.
Okay? And you want to have the accurate diagnosis, but there are times when the diagnosis is missed, okay? And one of the things that, and I'm biased towards you, let me say that up front, okay? But one of the things I'm very careful who I refer to, okay? And one of the reasons I refer to you is because of what you just said. You don't just take what they say and then diagnose them based on that. Yeah. And in the years, I have seen that, though. I've seen individuals say that they've went to a general physician or they went to a psychiatrist and they were there for 5 minutes and then they walked out with medication. Yep. And one of the things that you said is I'm not just going to give you that medication without you believing and understanding that they meet the criteria, okay? Which is so necessary, and one of the reasons why I'm so glad that you and I work together. Now, I'm kind of jumping because one of the things in your introduction was that you also help with withdrawal and deprescribing, okay? Could you tell us a little bit about that and what that entails?
Absolutely. So that's another place where we're currently at, that I think psychiatrists really have to come to terms with the fact is whether these medications are actually causing more harm.
Correct.
A lot of these medications were never intended or studied for long-term use. And we were taught, because I started residency in 2001, so I was in the boom of,
Correct.
all the newer medications coming out and kind of psychotherapy being pushed to the side in psychiatric training. I was I'm still thankful today for the program that I started in that had a lot of emphasis on psychotherapy. So that's kind of ingrained.
Correct.
And I definitely integrate that into my practice. But yeah, psychiatrists, there's the moral question and the ethical question of whether these medications are causing more harm. And going back to, we got to get to the diagnosis to begin with.
Correct.
And that's not just signs and symptoms in the psychiatric sense, but also medically. There's a lot of medical illnesses that can mimic, So in an insurance-driven environment, we have less time, and it's so easy to just say, here, 10, 15 minutes.
Correct.
What you need is a medication. No mention of lifestyle changes, sleep, relationships, therapy even. So it's just like, no, boom, because I have a waiting room of people.
Correct. Correct.
Full of people that I need to crank out. So personally, and a lot of things are my opinion, of course. A lot of people may not agree. But yeah, we have to come to terms with the fact that we are taught how to get on the train, but not how to get off.
Excellent. Excellent analogy. And you say your opinion, but I also say that opinion is backed up with years of experience.
Yeah.
And thousands of clients that you've seen.
Yes.
And when we see those individuals hurting, okay, we want to help them, okay, because we have that service heart. However, when it comes to the thing that is helping you is now hurting you, and getting you as an individual to see that, and getting the family to see that, because like you said, you've been told through not diagnosed by a psychiatrist, but you've been told by family, you're bipolar, something's wrong with you, you're so narcissistic, and we're not saying that those things don't exist, okay, but we're saying that the experience of those things in the moment of an argument and then being called that doesn't necessarily mean that you are that.
No. And a big part of my practice now is, if I think when I was training, people were novel to medications. So I was starting from scratch. Most of my practice now is reviewing their 15 medication long list and untangling what's there, how did this even start?
Correct.
And if it started because of a divorce, because of a grief, a loss, that if I can go back and really go through their history, very detailed, including medication, including medical issues, including trauma, like my evaluation takes an hour to an hour and a half.
Yes.
It's not a 15-minute insurance, tiny snippet of your life. And I try to get records and I try to do everything possible to understand this person and in retrospect see. And so many times I discovered this was not your diagnosis to begin with. Now you're on these medications. What do we do now?
Correct.
And that's where, again, a lot of education and going over with them point by point. I believe this medication is causing this. And then you had to get this one because of this one.
Correct.
And then they had to add this one because of this one. And then none of them were intended for long-term use. There's a lot of abuse of substances, going into the, medical marijuana, but then that's like a very potent amount of cannabis.
It is.
And so then that's causing psychosis. Then they're diagnosed with schizophrenia. Then they're on an antipsychotic. And it could have been just substance abuse to begin with.
Correct.
So then the medication withdrawal process can be extremely difficult. It is extremely risky. And, I take the time to let them know this is what I think, this is what I propose we do, and this is how we would do it. Because it is a very delicate process. There's a lot of people out there that, they're trying to come to a consensus
Correct.
on how to do it in a standardized way. But everyone is individual. Every brain is individual.
Correct.
So for each and every patient, I come up with a treatment plan of how we're going to do this. And that can involve even going to like liquid forms of medication, using compounding, because it has to be such a slow and careful reduction.
Correct.
So that we don't confuse medication withdrawal from recurrence of symptoms. And that is what happens every day in psychiatry, that they start getting off medication and then they think that they're getting symptoms back, and it's probably just withdrawal. Because
that what I call that familiar spirit, and then that familiar body reaction immediately brings us into that fear, flight, freeze things that often happens. And you're like, I can't go back. Okay.
Yeah.
And you said something earlier that's so important, that you look for the origin though. Let's talk about the origin of where this actually came from.
Yes.
Okay. And again, that means that we may have to unpack some things and really go back into that history, in most cases, family history and childhood history that also may, as you say, be compounding it. Okay. So with that being said, there was a time, and again, I started practicing back in the early 90s, and it used to be this thing called Ritalin.
Yeah. Oh,
Okay?
yeah. And
So,
since the pandemic, that's a huge issue.
And that's what I wanted to find out now. So from your perspective and your clinical experience, what are you seeing is now the psychotropic med that is being used in a positive way, but also is being abused as well? What would you say would be kind of the top three that you're seeing out there?
So interestingly, I think at this point, some research says that about anywhere between 13 up to 20% of people in the U.S., adults, are on an antidepressant.
Okay.
That's in treatment in and of itself, right? About 17% on antidepressants. And then following those, it's, very common, the stimulants, benzodiazepines, which are your Klonopin, Ativan, Xanax. So, and the stimulants and the benzodiazepines are the most abused. And unfortunately, during the pandemic, since we all went online, then we had some corporations that just started cranking out scripts that even led to a nationwide shortage of medication. So my patients who actually needed it, who had been diagnosed, had gone through the work of getting an actual true diagnosis, didn't have their medications available. And can you imagine a mom at home working and doing school for the kids, the kids trying to be sitting in front of a laptop, and without having availability for the medications for their child or for themselves? Correct. So it's a huge issue. It is one of the biggest culprits for acute psychosis in someone who never in their lives had psychosis and going back. Misdiagnosis.
Correct.
The person reports all the symptoms. They've read the criteria. They know exactly what to say. And boom, they would be getting medications a lot easier than it would have been, 6 years ago.
Correct.
Yeah.
Correct.
So there's a huge problem with that. The other problem, and the stimulant problem is more recent, but really to me, one of the bane of my existence is benzodiazepines. Okay. Because those are the tranquilizers. Those are the ones that everyone's coffee, drinking coffee all day, doing stimulants all day. And then, I have insomnia. I'm having panic. I'm having anxiety. Because they're used to being on all these stimulants. The cannabis products are very stimulating because of the percentage of THC. So everyone's walking around, you know.
Correct.
So everyone wants, oh, I want my Klonopin. And they come to me asking for it. That was more common way back, you know, when I was first seeking benzodiazepines. The problem with that is stimulants are easy to come off of. The worst that can happen is you're going to be tired and hungry. And if you truly have ADHD, it's going to be difficult. It's going to be very hard. Your day's going to be hard.
You said something, though. If you truly have it.
Truly have it.
And that's the power of the mind. So as a person thinketh in their heart and their mind, so are they. And that's why it's so important to have the medication and psychotherapy working together.
Yeah.
Because, yes, you can be on the medication, but the issue is not being on the medication. The medication is to help stabilize you so that you can address the issue and then come off of the medication.
That's my plan for almost everyone. Yeah. So, but with the benzodiazepines, unfortunately, that can actually be a deadly withdrawal.
Explain that.
So, benzodiazepines have similar mechanism of action as alcohol.
Okay.
So if you're someone who drinks alcohol every single day, large amounts, what happens when you all of a sudden say, I quit, I'm done? You're going to go into withdrawals and even delirium, and it can lead to death.
Correct.
That's how benzodiazepines are. So the problem there is even primary care. You know, a lot of people in the 80s and 90s, it was so easy to be like, oh, you're crying in my office. Let me give you some Xanax. You'll be fine. But back then we didn't know. Then in the 90s, we started learning. Already in the 2000s and early in my training, I was observing like this is a problem. And even 89-year-old little old grandma is going to be kicking down my door for these medications. This isn't normal. This isn't what I signed up for. This isn't, you know, and it is because the withdrawal is so extreme and can be so uncomfortable and life ruining that these medications were never intended for more than 2 weeks. And I have people that have been on it for 20 years. It can take me over a year to taper someone off of that kind of medication.
And you said something from a mental health perspective. As a clinician, we do not like to be uncomfortable.
Exactly.
We do not like to be uncomfortable.
It's so easy to be like, listen.
Exactly.
Here
We
you
don't
go.
want to. We don't want the pain. We want pleasure over pain. Okay, and we don't want to feel it. And the reality is that adversity, though, actually strengthens you as well. Now, we haven't really talked about it, but I also want to ask you about young people, our teens, our adolescents, and even our college students. What are you seeing there? Where are we with regards to that population and medication?
So, ironically, they are seeking, they want to be on medication, they want to have ADHD, they want to have autism, they want to have even dissociative identity disorder, which is so rare. I'm not saying it doesn't exist.
Correct.
It is, and I believe it is a neurological. It's more on the neurological side.
I agree.
So it's not that I you know, and I'm not anti-medication in any way, shape, or form. I just believe that we have to be so much more responsible with them because those brains are still developing.
They are, and that's why that's one of my slogans.
They're
I say,
half-cooked.
yeah, I said I'm not for or against medication.
Exactly.
I'm for psychotropic medication being used appropriately. Because
And
if you don't
prudentially.
exactly, and again, when you have society propping it up as the thing to do, the thing to be, are you not on meds? You need to be on meds, you know. And again, the question becomes, how do we assist in sometimes breaking that cycle? That's very difficult to break. Okay, and I have a lot of faith-based clients as well. Okay, and one of the things I also see with those of faith that rely on God and their relationship with God through Christ heavily, and then their struggle at times to be on medication. Okay?
That's the flip side,
That's the flip side. Okay, so how can we help them as well.
Yeah.
That you can definitely your faith in God through Christ, and then being physically on medication, that does not mean that they'll have to work against each other.
Exactly.
Okay, can you speak to that for a moment?
Yeah, actually, it was through psychiatry that I came to conversion.
Wow. Okay.
Yeah, because I could, once I was in the trenches, I could literally, I believe it was a grace that I could see there's a line here. This is what I can do. And beyond this, it has nothing to do with psychiatry. It has nothing to do with medicine. It has nothing to do with neurology. This is something else. And what is that something else? The spiritual realities. It's a spiritual reality. And in patients that have faith, to me, that's an advantage because with the absence of faith is the absence of hope. And
Correct.
when someone is in that hopeless place, that's a lot more difficult to deal with.
It is.
And then from the faith aspect, religious leaders, it's a mixed bag. Some are pro and some are like absolutely not
Correct.
for medication, And so because I see patients from every walk of life, every single, obviously I only see adults over 18,
Correct.
but I see from every walk of life, and I'm very open and very accepting and I do take that as a part of my assessment where they're at with their faith, because it is a lot more difficult to bring hope. And then on the flip side, it's difficult if they're being dragged in because they really need it, but their pastor or their priest said, don't let them give you medication, and blah, blah, blah. So I'm very open. I'm a person of faith, and I let them know if they have faith and they're coming from that angle, I let them know, listen, God created me too.
Correct.
And he put me through college, medical school, residency, fellowship, all these sacrifices only so that I could be here today to look at you as a whole, as a person, body, mind, and spirit. So, and then they're like, okay.
Correct.
Okay. They're a little bit more open. And I also tell everyone, the first visit, I'm like, not everyone walks out of my office with a script on the first visit.
Correct.
So I'm not going to say, if you don't take this, you're going to die. I don't scare people.
Correct.
I don't scare families. I just let them know this is what I propose. And I understand. And you would be surprised the amount of people that come to me as a psychiatrist knowing that what I do is prescribe. But they're like, I'm here, but I don't want medication. And I'm like, that's fine. I will help them find alternatives. And these days we have, like I said, I had put in my bio that I'm very interested in non-pharmacologic interventions. So, there's a lot of very good research now with metabolic psychiatry.
It is.
A lot of symptoms may not be just that you have generalized anxiety, schizoaffective disorder, bipolar. It could be more of a symptom of a metabolic disorder because the brain also needs to be metabolically healthy.
Correct.
So there's 100 years of research of the ketogenic diet for epilepsy, for people that didn't respond to anti-epileptics, which we use as mood stabilizers.
Correct. Correct.
So with 100 years of research, now there's a lot of good research going on in Harvard, Stanford. There's a lot of research going on that extrapolates that information to mental health. And so when people come to me and say, I am suffering, I need help, but I don't want to get on these medications, then I offer, there is something that we can offer these days. So I'm a big proponent of lifestyle changes, sleep, improvement. Therapy is always my number one recommendation. I'm going to start with my first recommendation is going to be therapy.
Correct.
Because you're going to see me maybe once a month, maybe in 2 weeks. But usually once things are nice and smooth, you see me every 3 months.
Correct.
And I need you to be in therapy. I need you to see someone weekly because there's a lot to untangle here.
And that's the importance of the holistic approach, which is why when I started the podcast and started it back up and reboot, so to speak, it's like, okay, no, let's deal with the physical, the psychological, the emotional, social, and the spiritual.
Exactly.
Because we are so complex in who we are. And like you said earlier, I do believe as well that God has given us gifts and talents and given us different people in different positions with those gifts and talents to help and to serve.
Yep.
This has been awesome, and I have got to have you back if that's okay. All right.
Absolutely.
And I want to just close by this. Okay. If there was something though that you could somewhat summarize as a closing statement to those who are listening, who may be struggling with whether to get off psychotropic medication or to stay on the medication, or to whether or not to prescribe it, as far as to have someone in their family be on it. What's a message, or what's something that you would leave them with?
I would say, there is a lot of hope. Things can seem a little dark with the environment in medicine and all of in access and everything. But I would say, look up who you're being referred to. Really look at their background. For better or worse, we have the surveys that people do.
Correct.
That, and then you can see what other people think about it.
Of course.
That
Yeah.
in psychiatry, that's always a mixed bag of worms.
It is.
But, it's a mixed bag. But do your research and be your own advocate. Even if you go to a practice where the doctor just wants to be in and out in 15 minutes, let them know and ask, is it possible for me to come off of these medications?
Correct.
How would we do it? I understand it's difficult. Would you be willing to take the time to walk with me in this? Because it really has to be someone that's willing to do the work. It's a lot harder to come off.
It is.
So, and whether they're open to just doing an evaluation to begin with, really to see if it's indicated, if starting a medication is indicated or not, and you can only be your own advocate.
Correct.
And if you can't be, a family member should be.
Excellent. Yep. Excellent. Dr. Rodriguez, thank you so
You're
much.
very
I look
welcome.
forward to having you back. And there's a ton of questions that we didn't get to,
Of
but
course.
we will definitely get to them the next time. So thank you for coming to
Thank you
Matters
for
of the
having
Mind.
me.
Awesome. You've been listening to Matters of the Mind, a podcast that focuses on matters that affect the mind. I'm Dr. Rick Adams, licensed psychotherapist and professor of psychology and human behavior. Come, join me on the couch as we discuss matters dealt with, matters dealing with, and the matters that we avoid.